Hello everyone and welcome back to the latest episode of Nothing But the Tooth. It's a podcast series by the Malaysian Dental Student Association, MDSA. My name is Danindran Rajasekharan. I'm a member of Academic and Research Bureau of 2023-2024 tenure. We are currently at the Faculty of Dentistry, Universiti Kebangsaan Malaysia, which is located right in the heart of Kuala Lumpur. UKM is the alma mater of many accomplished dental practitioners, including our guest speaker for our third episode of Nothing But the Tooth. Do you guys have any idea who could our speaker be? Here's a hint. He is the 7th president of MDSA. If you guys guess Dr. Joshua Pei, bingo, you guessed it right. We are so excited to have him back here since he's back in Malaysia. In 2019, Dr. Joshua proudly graduated with bachelor degree from UKM, where he distinguished himself by receiving the esteemed Tun Razak Award. This award, renowned for honoring excellence in both academic and also co-curricular activities, underscoring Dr. Joshua's exceptional achievement. Subsequently, he dedicated himself to government posting right in Kuala Lumpur before venturing into the realm of orthodontics at the University of Adelaide, where he continued to pursue his academic aspirations with enthusiasm. Today, Dr. Joshua will be sharing about his ever-growing experience from undergraduate to GAP and NDOP life, and now what it is as to be a postgraduate student. Moving on, we will dive into more academic-related topic, malocclusion, where it is more about how teeth and jaw is not lining up as the way they should. I bet we are both curious to hear more about it from an orthodontic student's point of view. As always, if you're ready, let's go. We will give you nothing but the tooth. Hey there, Dr. Joshua.
Hello.
Thanks a bunch for being here today with our podcast today. It's awesome to have you here in UKM. So, before we kick things off, would you mind to give a little sneak peek for our audience here?
Sure. Hi, my name is Joshua. I started dentistry in 2014 in UKM, this beautiful place. And thankfully, 5 years later, I graduate. And I went into specialization in orthodontics 4 years later. And now I'm in first year doing Declin Orthodontics in University of Adelaide. One of the most beautiful schools I've seen before.
Yes. Yeah. Right, Doctor. Would you mind to share more about your background right now and how is it like all going on?
So my background from undergraduate, you mean?
Yeah.
So undergraduate started in 2014. Back then, I didn't know much about dentistry. I just thought like it's a good way to, have a good quality of life. So my family are all teachers. So 4 of them are all teachers: my father, mother, brother, and my sisters. And I was the only one that undecided on what I want to do. So I thought about looking through the list of occupation and say, oh, dentistry seems pretty good. They have good quality of life and no one died because of toothache. And then you can go back home on time. And lastly, you can have the name title doctor. So that was what I thought about like when in 2014, being a dentist is pretty cool. So I tried and I got into UKM. So I was so happy to be here. And I started to do a lot of things here and there, play a bit sports here and there. Do you play sports?
Yes, I do.
Okay.
I play a few different sports.
Yeah. So I play sports and then I realized, you know what? I need to do something out of just studying. So I started joining society and MDSA was one of it. So I started applying straight away for president-elect, which is a bit crazy because people usually start from sub-4.
Yes, true.
So I straight away went for president-elect when I was in 3rd year and thankfully I was elected. So I've been serving for MDSA since 2017. And until today, I'm still invited for all these things. So thank you for inviting me. I love the name, by the way. Nothing but the tooth is very funny.
So yeah, it's very nice to hear about it. As a second year student, there's like a lot more for us to go. But hearing from someone who have experienced everything, it's definitely something that I'm looking forward to as well. So, Doctor, can you share a bit about your journey from dental school to where you are right now? From dental school to where you're right now.
Sure.
So what's the transition like from being an undergraduate to a postgraduate? And how's the studies been for you?
Yeah, so there's quite a lot of big. I'll just probably like dissect it to a few sections.
Okay.
So like first of all, when you're in first and second year in undergraduate, you're more like discovering what you want to do. And it's a bit harder to relate to dentistry because the first and second year is more like anatomy, physiology, biochemistry. It's like, where's the dentistry part?
True.
Then they will say, oh, that's oral biology for you. Then you look at oral biology and look at the 10 carton, like, oh, there's so many things that I don't understand.
Yeah, very true.
So like the first and second year is slightly harder. The second year gets a bit better with operated dentistry.
True.
And you get a little bit more like understanding what you do for scaling and stuff like that. So I feel like with like second year and third year with the progression, you get more interested in dentistry.
Yes.
So when second year, when I started to feel like a bit of dentistry, I was like, oh, this is something I can do for the rest of my life. I can. Back then, my best friend is a barista. So I was like, you know what? Let's open a clinic together with you being in my clinic. We have a cafe here in my clinic. We can have pastry, we can have coffee and stuff like that. And it sounds like very good because no other clinic have it here in Malaysia. That it sounds like a good business plan. Then I realized, people can actually away from dental phobia because of the iris now of everything like that is gone now because it's full of coffee, and people can have like a very nice croissant made really for you, and you're like, oh, croissant, so good. And then when you come over here to check the dentist, then all the fears are gone because they already do the desensitization through that. Then I realized as the year goes by, it's actually not possible to do it here. So if anyone wants to steal my idea of doing this, feel free to try, but you may get rejected because KKM don't allow this to happen because they need to have a specification of what you can have in a clinic. And then the second thing is, it's not so ideal because as you study in second year, there's oral health, there's this thing called Stevens curve. So you're not supposed to brush or do any spitting within 30 minutes because your teeth is actually at a lower pH value at this stage. So that doesn't really rhyme well because you're asking the patient to not eat anything and not brush your teeth after eating, but then you're doing this to them. So it's like not ideal. So that was my plan initially. So when I finished dentistry in 2019, I was like, you know what? That's it. No more studying. I'm done. 5 years of studying. There's so much pain and torture and all these endless hours of waking up 4 a.m. to study. I'm done with that. Then I waited until I went to KKM in 2020 and I got my first salary and I was like, oh, that's it. Because this is like my own personal experience because it may not be the same for everyone. I'm not saying that I spend more money. It's just that when I pay off all my bills, all my rentals, utilities, and I was like, if I'm going to work this for the rest of my life and I only have this much savings, I don't think I can reach my dreams and my goals that quickly. So after I got my first salary, I was like, you know what, maybe I need to change my plan a little bit. So I was deciding on, that's where I decided that I need to invest in myself. So a lot of people do different investments. They invest in knowledge, financial banking and stuff like that. But I'm not good at numbers. I'm better at gaining knowledge for dentistry and stuff. So I decided that, I can be a specialist, and instead of being good in everything, I just be good at something. Because it's very hard to be good at everything. I'm sure when you go to third year or fourth year, you feel like, oh, denture is so hard. And then you go to do filling, is this caries-free done? So you feel like there's a lot of things that you need to learn. And this is just the beginning. You are just touching the surface of dentistry. When you go into KKM, you go to private, you are the one that decide what you want to do. So when I get to that point, I was like, it's too hard to be good at everything. I need to learn about implant, I need to learn about braces, I need to learn about perio surgery. It's like, these are all the advanced things you don't learn in undergraduate. So I was like, you know what, just be good at something. That's where I started to search on specialization. And I realized braces is one good thing that I like. I always like to do braces, but I just don't know how to do it. So I started to do clinical attachment. I started to join study clubs, and I started to learn from a lot of people. I actually shadow like a few orthodontists to see how their day-to-day life would be. And that's why I realized that, this life is what I want. So I actually started, to get into specialization, you can't just decide, oh, today I wake up, the next day I can just apply for it. You can't. You have to go to the website. There's a list of checklists you need to do. Working for at least 2 to 3 years in general dentistry. You need to have a very good recommendation. You need to have research published. You may or may not need that, but it will be good points for you. And you need to have a membership of fellowship, for example, like MFDS or RCADS. So all these things is like, you need to prepare for it. So I took around 2 to 3 years to prepare for that, and I applied on my third year, and then I got in. So that's why I quit my job in KKM and I joined now in Adelaide.
Oh wow!
Yeah, it's a long journey, but I hope that was fun. Yeah, it's worth it. It's definitely a lot of crying, a lot of waiting, a lot of uncertainties. I was just telling you earlier on that if you interviewed me 2 years ago, I wouldn't give you the journey that I have today. It's probably like, you know what, I'm still figuring out my life. I'm still like, deciding what I want to do. And it's very hard for you to answer the question because people ask you all the time, so what's your plan? So that is a very hard question. You get it in second year, you get it in third year, you get it in fourth year, and you get it in fifth year, and you started working, you still get it. So it's very hard to tell you what's the plan, but I'm happy that I decided on this journey, and I'm happy to share it with you guys today. Yep.
Oh wow, that's such an interesting journey because as a dental student, as an undergraduate myself, I do get the questions. So what's your plan? What's your plan?
Yeah.
But from your point of view, it's something that it's definitely not easy, but something that I look up to.
Yeah.
So doctor, may I know how's your GAP and NDOP experience? I think we'd love to know more about it.
Yeah, so for the audience wise, GAP is graduated awaiting posting, and usually you get like around 6 to 12 months of break after your 5 years of study. And NDOP is new dental officer program, which you have to join the service for 1 year. It's a compulsory service. You can either join KKM or you can either join private to do that. And then in KKM, you get an option for 2 years to stay with the government. So there's a contract for that. So for my GAP, I finished in 2019. Okay. In around August. So September to March is my GAP. I actually went to travel. I went to USA because my host mother was there. So I was in exchange program before.
I see.
So I flew all the way back there to spend like 1 to 2 months with her. And it's very lucky that I actually got back in time because March 2020 is our pandemic. Oh. So I got back 2 weeks before the pandemic. Okay. So if I stayed 2 weeks longer, I would be staying in US for at least 2 more years, which is not a good deal for me because first of all, I wouldn't finish my NDOP.
Yes.
Second of all, I wouldn't have any money, and everything is 4.75 back then. So I can't really afford anything. I'd be like, host mom, can you feed me this, feed me that for 2 years, which is not ideal. But anyway, so I get back into NDOP in March 2020, and 1 week after I entered NDOP, COVID happened, MCO, and that's it. My first year of dentistry, I'm going to do so many fillings, I'm going to do so many extraction, nothing.
All went.
First year, all went to the drain.
Yeah.
So, but the first year was very fun because I did get to do like a different part of the community, which is COVID testing. I get to do COVID tracing. I was in the call center. So I really all my life was just calling random people from like Mont Kiara. Hey, do you have like this contact with this person? Have you been to this place? So it's a lot of hard work for tracing. And then the fun part is I even get to do COVID testing that, I travel all the way to a prison. And I wear full PPE, and then you don't get to experience it now, too bad. But when I was doing that, it's very scary because like this prisoner seems a bit big and, scary and buff, and they just feel like they're going to punch you in the face, that kind of thing. And you are doing the worst part, which is doing the nasopharyngeal swab. You're going all the way to the nose. So like I was hoping that, someone was actually holding their hands, or lucky they're handcuffed. If not, they're handcuffed, they're probably like, oh, hold me in the face. Yeah, because nasopharyngeal is very, very bad. It just goes straight to your nose and you just want to sneeze and something like that.
True.
So it's definitely not nice, but it was a very fun experience of having the first year during through the pandemic. So my dentistry part came second year and third year in NDOP, where I get to do a lot of extraction. I get to do a lot of denture. And I think denture is a very important part of your life. So get the undergraduate learning well, because once you finish, no one's going to teach you. How you're going to over-trim, over-extension, that kind of thing is all gained from undergraduate study. No one's really going to teach you how to do it because people are like very vague. Like, this one, maybe, this one, maybe. So undergraduate is where you can get the specialist training from prosthodontists to actually teach you what to do. Yeah, so get it well, get it done right, and that's where you can do very well from it. Yeah.
There's something definitely going to be very useful for most of undergraduate here. And how about GAP and NDOP work? So doctor, can I know, how does dental schools compare in different countries? And I'm sure you're someone that I can ask this question to. And doctor, can you please spill the tea? How was it for you when you packed up and started fresh in a new place, far, far away from your home country?
Yeah, okay. So I think the only way that you can actually experience different countries by joining them. So I wouldn't say that I know exactly how it feels like to be in other country. And the dental school, you can compare to a lot of places, but what I can tell you, like maybe Malaysia compared to Australia, right? So I think Malaysia curriculum is done pretty good. When I was in UKM, I feel like I was quite competent when I graduate. So maybe I can start my journey from comparing with my peers when I was doing KKM as well. So when I finished UKM studies, I go to KKM and work, and I compare to other peers who, graduate from other schools, I realized that the things that we learn is not too bad. Like, it's quite on par with what KKM is prescribing, for example, medication, or like the way of doing LA, INB, all these things is quite on par with what KKM standard is. So this is very good to begin with. And then the second part is the lab work that we have to do. Even though it's grueling, I'm not sure whether you're still doing second year, third year, and fourth year of lab work. But when I was studying, second year I have to do full lab work. Third year I have to do all my cases, and fourth year I have to do all my cases as well. Fifth year is where we can ask the technician to help. But that was what we started with. So the denture part, the prosthodontic part that I have in undergraduate helped me to equip myself to do well in KM compared to other countries graduate. For example, UK, Australia, and New Zealand, even though they are much better ranking in terms of schooling, but they don't really have too much lab experience. They don't have to do lab. So UK, Australia, and New Zealand, they don't have lab training, so they don't have to do any lab work. So no tip setting, no going to the lab, no staying back that late, no pouring your models.
Oh, damn.
Everything you do secondary impression, send it to the lab, they'll do the boxing for you.
Oh, wow.
And this is true because I went to Adelaide. I look at an undergraduate student, there's 80 of them. None of them have to do any lab work.
At all.
At all.
Damn, this sounds like a dream for...
They only had one
Yeah.
training session with the technician, teach them how to pour, teach them, show them how to do a teeth setting up, and probably that's it. Only one session. So they don't have to do any teeth setting up and know all these things, so or know all the jazz. But when it comes to KKM and work, because we only have one technician for one clinic, right? And you have 20 dentists coming in. So 15 to 20 dentists depending on where you go. So it's just so hard because they have to accommodate for so many of you. And there's so many cases. So one person has 2 cases, he has 40 cases to do, right? So sometimes I just, with all the knowledge I have in KKM, in UKM, it's easier for me to modify my denture. It's easier for me to help them with the teeth setting up because sometimes you go clinically, it's just different from your lab.
Yeah.
When you put it in, I'm sure you had that experience before. You put it in, the midline is off, and then the OA jet is like different. So you have to do it by yourself. And doing this with all the knowledge, I'm like, oh, you know what? I can take out this one, modify here, make the arch smaller. So a lot of people, they may not be able to do that well because they don't have the behind the scenes knowledge, but we do have the behind the scenes knowledge. So I feel like Malaysia training wise, making sure everyone do the lab work, that's a good training to begin with. In terms of, I think based on what I have now, because I joined Adelaide for postgraduate, in terms of how the communication with the tutor and the students, there's a big difference. Because over here in Malaysia, maybe we are a little bit more quiet. Whatever the tutors say, we just accept it. And that's part of our culture. But when we go overseas, there can be a little bit more questioning as well. So like when the tutor asks you a question, then you can just answer and say that, oh, this is, I think I read this before, this article says something different. But that could be a difference between postgraduate and undergraduate. That's why I'm not too sure whether I can answer it on behalf of undergraduate because I only had one. Yeah. But there's a lot of other differences. I think culture-wise is different. When you compare to like maybe countries like India, they probably have not all uni have it, but some uni may not have the experience of using rubber dam. So when you come to KKM, when during the COVID, we are all forced to use rubber dam. So we as the youngest generation of NDOP have to teach the older people how to use the rubber dam. So that's pretty good knowledge that we have here in Malaysia as well. So a lot of different things, but when it comes to extraction, then they are the tip top. They are the best in the industry because they probably do a lot of extraction back then in India also.
True.
Yeah, so it's very different. Everyone's different. Everyone has different culture. So it's very interesting to talk to people and learn from them. And for those who are studying in Malaysia, be grateful. You guys have a pretty good system here. Yeah,
definitely. I'll be very grateful. Hearing from whatever you said just now, I feel like yes, whatever we did is not easy, but then definitely it's going to be worth it.
It's definitely going to be worth it. Yeah, it's definitely going to be worth it for sure.
Yes. Right. Thanks, UKM. Yeah. The first time you're leaving your family for this long?
No. I left my home since 17 years old. When I was 17, I left to US for 6 months. And since then, I never really go back to Taipei. That's where I'm from. Because I did my UKM study. I did my matriculation in Goping, Perak. I did UKM for 5 years. I went to KL to work for 4 years, and I went to Australia. So I really never go back to Taipei. But that's what I believe in, because sometimes when you're younger, it's okay. As long as you have the good relationship with your family, that is fine. So what I do is, even though I'm away, I never make them feel that I'm away. I always give them calls to maybe 3 times a day, 2 to 3 times a day, so that they know that I care about them. And I'm always around. So they never felt that I was actually far away.
Yeah.
So that's one way, maybe an advice that I can give to people who are studying overseas or are studying far away, that always keep in touch with your family members because they do love you.
Yes. True.
And they do want to care about you. But what you can do is just give them some little time and they'll appreciate it a lot. Don't feel bad for leaving the home because you're making your own life now. In future you have your own family. In future you have your own working. So you got to work towards that direction.
True.
Yeah, but at the same time, don't neglect your family for raising you up. So give them a call, tell them you love them. Yep.
That's something to hear about from experienced dentists.
I thought we were talking about dentistry today. We were talking about family too.
Talking about families, yes. Fascinating. Okay. I've always been curious about life after graduation. So, doctor, could you please give us a quick rundown of the registration and application process for MDC and also the eDentist portal?
Yeah, so the reason why I got this question probably because I was the one that designed the MDSA portal for this segment itself. So when I was doing my post-graduation application, post-graduation as in for dentists, not for post-grad study. So when I finished studying 2019 and I was like, where do I go next? There's not really a lot of guidance and seniors to help me with that. So I go through everything and I was like, you know what, let me prepare a portal and like a website so people can actually just go and refer to it. So I did this under official MDSA.com. I checked just now, it's still available. So good thing that you guys kept it. Thank you. It was under official MDSA.com under graduation, after graduation, life after graduation. And with that, you can find that the whole list is there. So first of all, you need to finish your study, get your transcript, and then you go to MDC to give them a call or email them. Sometimes it's faster to email them because it's hard to get their call. So one representative say that you finished graduation from UKM, there's 40 of you, you want to have like meet up with them to register. So they will give you a date, maybe 2-3 weeks later, and then they will say maybe 20 people per batch per time. So you may have to do 2 different timing. So once you got that date, get the MDC registration, that's where you get your photos, your APC, and you can say that this is my first official dentist certification because your name will be there, doctor something. Your first doctor application will be there. And then after that, you have to do SPA, which is to work with the government. But I'm not too sure with the new system now because apparently you can work with the private sector as NDOP. So that could be a different pathway for that. And then just wait for eDentist, which is the selection of placement. Again, this is for KKM. I'm not too sure about private sector. You may have to ask someone newer. And then you attend the PTM, which is the Program Transformasi Minda. Everyone has to attend this because that's where you train to be a government servant and a dentist. And then just report for duty. So if you want to have a full rundown, just go to officialmdsa.com/step-step-guide. Or you can just go from the homepage and look for it. I'm pretty sure it's still there. Okay?
Yep. So life after graduation, I probably have to remember it, but not for now. Maybe another 3 years time. Hopefully, I'll go there and get my details there.
Probably it's different, so you may have to check again, but it's a good start.
Yeah, definitely. Okay. So, doctor, so I have this one small doubt. I don't know if it's small or not, but you can decide it. So, what factors should most dental graduates consider when they want to decide about pursuing a career as general practitioner or even specializing in like particular expertise? Like we have so many expertise. We have prostos, we have endo, we have OS. We can go on, keep on going like yours ortho. So, what factors do you think that we should be like braining?
There are a few things that you need to think about. So the first one, that's maybe just question. So always question yourself to begin with. So what is your interest? Do you see yourself doing this for the rest of your life? So if your interest is a bit of everything, then general practitioner would be good for you. If your interest is particularly for prosto, then you want to do that for the rest of your life, then you can decide on that. But there is one unknown factor that I'm not too sure how it's going to affect in future is because of AI that may come out soon. So my question to us is like, what does the market want? So right now the market for general dentistry, they want you guys to work for maybe 6 days a week in private sector. And usually most of the advertisement that they have for job vacancy is 9 to 8, which is 11 hours, 9 to 6, which is not too bad, or sometimes 8 to 8, 12 hours. So quite a big opening hours kind of thing. But with the increasing projection of dentists coming out every year, and with the increasing AI in terms of their efficiency, this is something that I'm not too sure about.
Yes.
So my concept for myself getting the specialization is I'm not too bothered by the AI, because even if AI comes over, I want to be the one that, be able to change. I want to be the one that operate the AI.
I see.
So that's why I need to be good in my field. So if AI takes over orthodontics in future, which is, I don't know when, which could be tomorrow, which could be like far ahead, which is what we are doing now with aligners as well. But sometimes I feel like I'm lacking a lot of knowledge in terms of that. So I want to be good at this thing, be good at one thing. And when AI comes over in future, I'm the one that operates the AI. I'm the one that, decide what to do, what kind of treatment planning. I'm the one that troubleshoot. So that's the reason why I decided to go into specialization. One of the reasons why. But yes, talking is easy, but the reality is not everyone can do that.
Yes.
And there's one thing, like, for example, what is your financial capability? Going to study again for 3 years, you don't have money to come in for 3 years. And don't ask me how I get my money. I have worked a few other ways to get it, and it's not easy. So not everyone can leave your family for 3 years and then just for study and have no income and didn't rely on someone else to do that for you. So it's really poor. It's a poor life out there to be a specialist, but the reward is abundance when you push through and just believe that one day you can, eventually teach people to actually be good. You can actually, service better because you know that you're doing the best for the patient. So whether you want to be a GP or a specialist, it really depends on how much time you're willing to spend in dentistry. And second of all, what kind of life you want in the future. Do you want to be a clinic owner? Do you want to be working for someone forever? Working for someone forever will be good or bad as well, because sometimes you can't change the rules.
Yes.
If they say 8 to 8, you got to be there for 8 to 8. You can't say that you don't want to go. You want to get it off. It's very hard for you to get it off as well, especially in private, because you have to work on the weekends most of the time. So these are the things you need to think about. And whether you want to invest in yourself, how much are you willing to invest in yourself in dentistry? Because general practitioner right now, a lot of the people are looking for jobs. They want people who actually have experience in braces, have experience in implant, and you don't learn this in undergraduate.
Yes.
So what we can offer as graduates is just scaling, filling, root canal treatment, simple ones, and extraction.
Yeah.
So this kind of thing is not the market is changing, I would say, for general practitioners. So you have to think about how much are you willing to invest in yourself. So I would say if you want to go to that pathway, take a couple of things that you're really good at. For example, orthodontic, just learn how to spend some courses that if you want to make yourself better in braces. Start with some simple cases. And then maybe the other part would be maybe learn some simple implant to begin with, so that in future, if you need to actually apply this knowledge, then you can. And most importantly, if you're having a general practitioner in future, get a really good setup, really good practice that you can actually learn from. Get a really good mentor, because that's where you learn the most. Most of the learning comes after graduation. Most of the working experience comes after graduation. So if you are bad at taking out teeth right now, it's fine. If you are bad at doing fillings, it's fine. Because you get to do 50 fillings in future, you get to do more and more. Right now, I would say I only had 8 teeth extracted when I was in undergraduate, or maybe, I don't know, maybe 20. I forgot the exact number. But right now, I take out in KKM, I can take out 15 in one day.
One day.
Or maybe 20 in one morning.
I see.
Yeah, so sometimes it's just the real practice comes after. Yeah, so a lot of things you need to think about. It's not easy for GP and specialists, but you need to think about the end goal. What do you want to do? Sometimes people may get away from dentistry, which is fine. You have the knowledge and stuff like that, which is sometimes it's not glorifying, that people think it's not a glorifying idea because they spend so much time in dentistry, but sometimes it doesn't really make them happy at all. They just can't see themselves working 6 days a week. So it's really not happy for them. That's why they moved to photography. Some went to open up a travel agency. They became a tour guide, and they are much happier. So whatever you do, always think about your mental health, think about your bank health, financial health, and then think about what your family wants you to do, because eventually when you start working, you need to work with your family as well. I don't want to be selfish. I don't want to go there just for my selfish desire. I want to have someone to come together with me. So always ask them, do you want to join this journey with me? And thankfully, my wife said yes. So that's why I'm here today. Yeah.
Wow, that's a lot of question marks to ask myself, or anyone there. I'll ask whether to decide, should I expertise or should I not?
Yeah, I think is always like good idea to always ask yourself what you really want and what can you do in the future, because like I say, no one really knows the answer but yourself. You have to decide what you want to do. And if you go to this pathway, invest in it, then just go through it. Don't just stop halfway. Yeah.
So at the end, it's your life that you want to live through. So the rest of your lifetime, something you're going to spend. So better make the decisions according to factors from all different angles. That, just like our Dr. Joshua said, yes, very true.
I think if you really want, take your time. Don't decide too quickly. What I did was I went through all different specialty, and I know someone from there. I talk to them. I will go to shadow them. I shadowed a lot of clinics when I was younger. When I was in GAP, I shadowed like at least 6 to 8 clinics, just to see how their life is as a private owner, as a associate, as a specialist. So I know what kind of life that I want to adapt to. So take your time, learn from people, talk to people, and if you want, shadow them to see whether this is the life they want.
So that's when you know that I wanted this. I wanted ortho. Yes.
Exactly.
That's a really good advice, I would say, for most of the undergraduate or postgraduate to whether to like go through which kind of expertise. That's something. Okay, so Doctor, thank you very much for shedding a light on those aspects for dental education. So it's really some insightful stuff for everyone here, whether to like you're still in the dental school or you're out of dental school. Yes, something you should know, because there are a lot of questions you need to ask yourself, ask people around you to gain some insight of stuff. So now, can we pivot to something equally intriguing? Like, yes, we go for like some curricular topics, maybe malocclusion. Okay, so Doctor, can you give us a lowdown on what malocclusion is all about? So because I would say it'd be awesome to hear from orthodontist point of view.
Not orthodontist yet, but you gotta, when you come to the world of dentistry, you have to be very clear on the terms and definition. So you can't call yourself an orthodontist until you finish 3 years of full-time graduate. So anyway, yes, malocclusion. Yes, we can talk about malocclusion. So my ideas of malocclusion and in undergraduate and postgraduate is very much different. In undergraduate, I'm always talking about class 1, class 2, class 3, incisor. What's it small for me? So when I was in first year and second year, I keep doing that. Okay, it's small for me. Class 1, class 2, or class 3, and then something like that. But when I study as a postgraduate, then there's more to it. So maybe we give a definition first. So that's what we usually do in academy. So the definition of malocclusion. Ideal occlusion, definition of ideal occlusion is the term given to define a dentition where the teeth are in the optimal position, both within the mandibular and maxillary arch. So they are talking about intra-arch, within the arch itself, and also intra-arch when they occlude together, and they should be in the ideal position. And then you need to quote where is this definition from. So this is from Martin Copeland, so one of the textbook there. So this is how you get points for undergraduate as well, if you want to impress your tutors. So definition first. And then so malocclusion is defined as any discrepancy from the ideal occlusion. So that's one way you can tell them as well. So importance of malocclusion, there's a lot. I think I would just put it into 2. So number 1 is health. Number 2 is oral health related quality of life. So health can be differentiated to maybe dental health and periodontal health. So let's start with dental health as well. So when you have crowding too much, even though they say that you can clean your teeth well no matter what you do, sometimes it's just hard because you can't find the ideal patient all the time. So when you have a crowding that's rotated like that, the teeth is rotated in the middle, you have an area that is very hard for you to clean. And that's the fact. So with braces, it can actually help with reduction of caries problem and caries, because you can clean it better. But obviously the study that says that it doesn't matter. As long as you floss your teeth well, as long as you can brush your teeth well, it doesn't matter. But from experience-wise, I've seen multiple patients who have crowding in the areas of crowded, for example, rotated teeth in the middle. The gums are usually inflamed, and there are quite a lot of plaque as well and calculus. And sometimes you just feel bad for them because they try very hard to floss it, but the angle is just so hard for them. You're gonna turn around here and there, you make a loop around your hand and that kind of thing just to reach the angle. It's just very hard. So first of all, it's just the dental health for caries, and for example, perio health is more like gingivitis. Second of all, we have crowded teeth on the lower incisor. Sometimes when it's too crowded, you are pushing the teeth forward like that. And what happens is because we have very thin bone at the labial surface, near to the lower incisors, when you push it procline like that, there are a chance that recession can happen because you're pushing beyond the bone limits.
I see.
All right. So with braces, when you put it into the right position, being upright, standing on lower incisors, then it can help with your periodontal health as well to reduce some recession. Okay. Some people will say that recession happens after braces, which is very common, but sometimes to begin with is because the teeth was already rotated. For example, the central incisor is like a butterfly, and then when you have a butterfly for a long time, then you have some recession happening before that, with all the plaque accumulated, and you can't brush it well, you can't floss it well. And when braces, you bring it back to normal position like that, then you can see a black triangle between the central incisors. That's not usually done by the braces. Sometimes because gingival recession already happened before that. So when it comes back to normal, that can happen. But essentially, there are very, very different ways that braces can help with, reducing gingival recession as well. So we got to be really careful. With all the proclination of the teeth, with a lot of tooth brushing, it can actually cause more abrasion. For example, a premolar that's a bit more outwards in the arch, a premolar on the canine is slightly more, for example, buccally procline like that. When you do a tooth brushing, because we always do a horizontal, even though you ask them to change to modified best technique, you can do 45-degree gentle brushes, round. When you go back home, so a lot of them are doing horizontal movement, so you can get a lot of abrasion around that area. So with braces, when you put it into the alignment, then there's less force on that, and then that can help with the reduction of abrasion as well. And periodontal damage in terms of teeth bite, we can have that with braces as well. When you have a class 2 teeth tube, you have an increased overbite that's 100%. The lower incisors can actually be biting on the palatal surface of the upper central incisors, and you can see that when they open up their mouth, you can see there's actually gaps. There's actually bite marks around the area. And in future, if you keep doing that, no changes, then gingival recession can happen again, and then they can have potential bone loss in future, and the teeth can become mobile.
I see.
And if you reverse the class 2 teeth tube into anterior crossbite, then you get the same effect on the lower incisors on the lingual as well. So braces can definitely help a lot in terms of dental health and periodontal health. So last but not least, regarding dental health, there are a lot of unerupted teeth that we can actually bring it down with braces. So pretty cool. You know that unerupted canines, so like canines that we have here, is the second most common impacted teeth after wisdom tooth. So wisdom tooth infection is very common to see, but unerupted canine you can see quite often as well. You don't really see it here in undergraduate because the patients are filtered. But when you go to the real world, when you see the patient within like 11 years of age, 12 years of age, and then there's no canine coming out, it's probably impacted. So I see it quite often in my practice as well. So with braces, we can pull it down. We can work together with the periodontal department or oral surgery department, create like a small exposure and put a gold chain there. We put a little button on the teeth, and then you can put a gold chain, and then we can slowly bring it down with gentle force. So if you don't do that, there's high chances of maybe ankylosis, maybe root resorption of the neighboring tooth, because the impacted canine is pushing on the lateral incisors on the root. So things like that's not good, and then eventually you may have cysts. So if you learn in 4th year, there's oral pathology, that's cysts that can be caused by inflammation, or some of the bacteria can go in there as well. So those are the things that we're trying to avoid. So braces is not just aligning teeth, it helps with a lot of health as well, dental aspect, periodontal aspect, and to oral pathology aspect as well. We can try to avoid that. And I was talking the first part, that's dental health, periodontal health. The other part is oral health related quality of life. So those are the things that we usually see. So braces can make people feel like, having a better aesthetic.
Yes.
Sometimes braces will definitely help you with the way you smile, that's for sure. We always try to achieve the golden proportion. So you will learn this thing in maybe 4th year in aesthetic. So that's a golden proportion that we try to achieve that as well in braces. And there is a lot of things that they make them feel more confident, because now that their teeth is aligned, they just smile more. I see more patients that they never smile in their life because their teeth are so crooked, and you can just laugh at them, because to you maybe, to us maybe here in the culture, it's so common to see crooked teeth. It's not common to have a crooked teeth at all in the Western culture, because a lot of them, they have braces when they're younger, and they have like this exposure to dentistry when they're younger. So having a crooked teeth makes them feel really insecure, and they really can can become a little bit like socially awkward as well, because they just don't want to show their teeth at all. So circling back part to the first part, when I mentioned that there are two different aspects to it, the dental health, and then the second part is oral health related quality of life. So this is where people usually see more often, for example, aesthetic, the feeling good about themselves after having braces, and maybe not being bullied. And you'd be surprised, in UK, there's 12% of peers or patients who actually had reported case bully because of their teeth being protruded, they have increased overjet, they don't like their appearance, and then just because of not having braces, 12%. And funnily, I was actually one of the victims as well when I was younger, because my teeth was actually quite crooked. So growing up, I don't really have the chance to do braces because my family cannot afford for braces and stuff like that, and my case wasn't suitable for GP, and I have to send to specialists and stuff. So to begin with, I had to learn how to overcome my fear of showing my teeth. So I started practicing how to smile, just my upper teeth and stuff like that, and it makes me feel better. So funnily enough, that research shows that even though the case bully is actually quite often, there are reported people who actually feel bad about themselves, but it's all short-term effect. After long-term, then people actually feel like they're okay and accepted their malocclusion. But yes, braces can definitely help with malocclusion, making people feel better. I feel better now, before without braces, but definitely made me feel better having to have like a straight teeth that can show people my smile and things like that. And second part is maybe aesthetic. Some people would think that having braces would actually lose weight. I would tell my friends, if you want to lose weight, you got to pair up with a good diet plan. So people actually lose weight from braces because they can't really eat too many things like hard food, too many crabs, or like all the steak and stuff like that. They have to make it into small pieces, and they just think it's too much effort to even eat a steak, too much effort to make it into small pieces. So they just like, I just eat it when I finish my braces. So that's why people lose a lot of weight. That comes with the diet plan. The mouth and braces is all the way up here, your body is all the way down here, so it doesn't really affect it that much, but it comes with the diet plan for that. For in terms of making your jaw look slimmer, like how some of the idols, they claim that I lose weight because of braces. Some say that you are doing plastic surgery. It may not be affected by braces because braces can actually make yourself, like the muscles, become a bit stronger, but it's not proven. It's just that you are not eating as much. That's why your face looks slightly slimmer. But in terms of plastic surgery, that it looks like you've done some plastic surgery like genioplasty and stuff like that. Braces can't do that. Braces can't change your nose. Braces can't change your jaw. It's just maybe the way that you perceive as thinner. But braces do pair with surgery, for example, orthodontic surgery, to change the way that your jaw looks, and that can be affecting your jaw profile, your skeletal profile as well. And that is a wonderful thing about braces, because we can actually help people to achieve a better occlusion with orthodontic surgery. So that is the surgery that we have in braces, not plastic surgery, not rhinoplasty. Yeah. So yeah, that's some of the benefits of braces.
Oh, there's quite a lot of benefits, and so it's the same as the importance for correcting the malocclusion as well.
Yep.
All right. So, doctor, so there are a lot of way of malocclusion, class 1, class 2. So, can I ask you this? So, what are the most common classification used in identifying these different various like malocclusion patterns?
Yeah, so this is a very favorite, I think one of the most common question that people get in exam. And as undergraduate, again, my answer will be different from now. So back then in undergraduate, it's always about looking at class 1, class 2, class 3 and stuff.
Okay.
I don't even know what is class 1, class 2, class 3 coming from. But I remember in my test in year 4, give the references for your malocclusion definition. So that's why we need to know all these things. So as a postgraduate now, I do see the differences. So I could classify it to 2 different assessments. First one is qualitative assessment, and the second one is quantitative assessment. So qualitative, it means that we are describing the malocclusion as we see. So there is basically British Standard Institute of Incisor classification, Angus classification, but we describe the malocclusion based on what we see. And quantitative is that we give them some marks, some points, and then where the points add up together, that just shows the different severity of the malocclusion. So that's the basic guideline. So if you want to give more test points to your written test, and depends on the question, if it asks for 50 marks, then you can start with this qualitative versus quantitative. Okay. If they ask for 10 marks, then just go straight to qualitative.
Yeah.
All right. So qualitative wise, there is few ways that we usually use it. The first one is incisor. So let's start from the front. Okay, so for BSI incisor classification,
Mhm.
so British Standard Institute, which is 1983. So you got to give the right references when you do your paper writing as well. So British Standard Institute states that for class 1 incisor relationship is that the lower incisor edge is resting on the cingulum plateau on the upper incisor, or they can be below the cingulum plateau as well. So class 2 would be behind the cingulum plateau for the lower incisor, and class 3 would be in front of the cingulum plateau for the lower incisors. So that's how I remember, because class 2 you gotta be in front, the teeth gotta be in front of something, right?
Yeah.
Upper teeth gotta be in front of something. For the class 3, the lower teeth gotta be in front of something.
True.
So that's how we can remember where the position is. So you just have to remember class 1, and then you just play around where it should be. Okay. But for class 2 itself, there is 2 subdivision. So if you look at people, you see them having a teeth that's flaring out like that. That is what we call class 2 teeth 1. So class 2 teeth 2 is that when the incisor has, like, the central incisor goes retrocline, and then the lateral incisor go procline. So it looks a bit like a Spider-Man when we do this. So some people have teeth like that. When we do a Spider-Man, you just rotate it like that. Then we have the central incisor and the lateral incisor procline. That's class 2 teeth 2. But essentially, they are still in front of the lower teeth. That's why they are still part of the class 2 family. Okay, so that's one way you can do it well in your exam. Then we go back to the molar. So molar, we don't use BSI, we use Angles classification, which is 1899. So there are, if we have a picture here, we can put it there for you. Like, for example, upper molar, you know that there's multiple cups. In first year, you have to draw your cups, right?
Yes.
So there is mesial buccal cups of the upper molar. Upper first molar, mesial buccal cups tip is resting on the lower molar. You know that there's 3 buccal cups there.
Yes.
So we are resting on the mesial buccal groove. So the tip will be resting on the groove of the lower first molar, and they will be class 1 for angles. And then again, the same thing, class 2, the upper teeth has to be forward. So the class tip would be anterior of the groove if it's class 2. And if it's class 3, then the lower teeth has to be forward. Then the lower buccal, mesial buccal groove would be in front of the upper cup tip. So that's how you remember. Just remember class 1, and then you just imagine where class 2 would be in front for upper teeth, and class 3 would be lower, would be in front. That's how you can remember, and that's how you get marks for it. So that's qualitative assessment. For quantitative wise is what we use in public system a lot. The reason why we have to quantify it, because in public system you have too many patients. You have too many patients who want braces. For example, KKM, you have, if you want to, you don't know who to send for braces. That's why we need to pick who has the most serious one. So in UK, Brook and Shaw, 1989, they started this classification for UK public system, where they can actually quantify who needs treatment and who gets a priority. So they created something called the IOTN, Index of Orthodontics Treatment Need. So this IOTN will help to identify what cases needs treatment first. And they go by priority, for example, missing teeth, increased overjet, crossbite, displacement of teeth, and overbite. So that's what we call mock door. And there's level 1 to 5. 5 being the need to do it immediately, or like more required to do treatment, and 1 being not required to do treatment. So that's 1 to 5 for that. So that is one way the Brook and Shaw created this to help public system to identify which patient needs treatment. So usually in KKM, we'll take IOTN 4 and 5 that needs treatment, and IOTN 3 and below would probably, like, you can go to other place to help with treatment, because we don't have, we can't accommodate for everyone. And they usually pick like the worst malocclusion in that one person itself. So that's how you can do like a bit of quantifying and qualitative assessment. And if you can write all this in your essay, in your exam, that would be nice. There are a few other ways for quantitative. There's IOCN, that's peer index, peer assessment index. There are a lot of different modifications. So if you want to get more points, then you can go on that. But I think with all these things, you can actually impress your examiner with that. Malocclusion. You get that when you're in 4th year.
So doctor, my another questions comes in now. So once you have diagnosed the issue, how do you go about the planning the treatment for that patient? So, and what key factors do you need to keep in mind for each person's treatment plan?
Okay, so maybe the audience that I have here is probably like more undergraduate students or people who are about to graduate.
Mm-hmm.
So I wouldn't know that you understand exactly what we are looking for fixed appliances, which is like fixed braces treatment. So maybe I just give a general view of what we are looking for when we started to look at one patient. So the first of all, look at the chief complaint. Always listen to the chief complaint and see what they want, because sometimes you see something that's abnormal to you could be normal to them. So the chief complaint will identify what's needed. For example, I can't bite on my front teeth. There is a sign of anterior open bite. So anterior open bite, okay, you need to keep in mind in your head, maybe I need to look for what's the reason for anterior open bite. Is it because the jaw is too long, or is it because of the tongue is protruding forward? Like that. That's why they can't bite together. So keep in mind what you're going to look for. So chief complaint is the most important to start off with, to see what they are complaining about. And then we start from looking from the outside. So when the person comes to you, look at the face, look at the jaw profile, look at the bone, look at the smile. That's what we call like a macro aesthetic. Okay, so when they go for macro aesthetic, when they look at the smile, then you can see how much the lips are actually showing, because there's a lot of things I'm looking at. The first of all, I look at the jaw profile to see whether they are class 1, class 2, or class 3. If they are 2 class 3, then we have to think about potentially breaking the bad news of doing surgery. But we can't just say that you need surgery right away. We still have to have X-ray to support the evidence to it. But in your head, you are going to that direction. Second of all, look at the position of the lips. Are they long or short? If they are too short, then you know that when they smile, they have a lot of gummy smile like that. Then you see, like, for example, Jenny from Blackpink, she has a little bit of gummy smile. So hers is acceptable. In research, they say that if you have 2 to 4 mils of gummy smile, that is fine. But if you have more than that, people can notice that. So you need to look at the lips length, and then look at how when they smile, how much teeth are showing. These are all the things you need to think about. And then I will start touching the patient and examine from inside. First of all, I look at the joint. You need to record now if there's any joint problem, because joint problem and braces is an ongoing debate. And some other Western country, they may actually sue you because they say that after having braces, they have temporal mandibular joint disorder, TMD problem. So always record it down in the first visit whether you have all this problem or not. If not, you can't protect yourself. So once, that's the first thing I look at, the joint, and then see how much they can open their mouth. Because if they can't open their mouth, I may not think about braces. I may have to think about giving them something else, maybe aligners that they can put in themselves. Because putting on braces, 3 hours, they gotta open their mouth for me. So you gotta think about all that thing. And then when we look at the lip length, and then we look at how much teeth are showing, that's all recorded, how much gums are showing. And then only we start looking from the soft tissue profile. Look at the lips, how strong they are. If they are very strong, it means that there's a high chance of relapse for the lower lip, especially because if the teeth are so proclined forward and the lips are too short like that, they don't have place to rest when they close their mouth. So incompetent lips are the things that we look for. So if you're having incompetent lips, the teeth are proclined and you can't really close the mouth to support it. Even with braces, when you put the teeth straight to upright, the length is not long enough to cover it. Then there's a chance of incompetent lips and the teeth can fall backwards again. Same thing, look at the tongue. How much are they having like a tongue protrusion? Are they actually resting on the teeth when they are resting like that? So this may actually affect as well. So, and then we have to be a dentist, look through every single teeth that we have and record it down, and to see if there's any need for example, fillings and stuff like that. And yeah, so a lot of things that we look at, and we take photos, we take study model, and we take X-ray. So I'm just going through like the things that I do in my postgraduate life.
I see.
And when we go back, we check the study model, we check the X-ray to see whether they align with the chief complaint or not. So the chief complaint, like I said, the first one, I can't bite with my front teeth. And then in the X-ray, we see that there's a long vertical axis, means that the face is a bit longer. So there's a chance that the jaw actually grow longer and forward and downwards. That's why no matter what you do, the teeth come back together, because that's the jaw problem. And that's where we have to lean to surgery to make it higher. We can't do braces and just pull the teeth, and then now they can bite together. No, you can't. You have to do extraction to do that. So that's not possible. So that's where you have to think about surgery and then what we can do for that. So there's a lot of things. Always look from the outside and then check the joint. go to the middle to see the small aesthetic, and then we look at the micro aesthetic, like for example, if there's any porosis, fluorosis, any porous teeth, and this and that, that's all recorded. And then we have all the information. We say that you can do this, we can do fixed appliances, or we can do aligners. We give them the treatment option, or we have to do surgery. And then that's only the time when we decide what kind of treatment plan would be the best. So a lot of things to look at, but always start from outside and go all the way to the inside. Don't just look at the teeth only.
Yeah.
I think one of my tutors here always say that if you are just looking at the teeth only, you're just like a monkey. A monkey can even do a feeding and restoration.
Yeah.
I think it was Dr. Shu who actually said that.
Sure.
Yeah. So you don't be a monkey. You're a doctor, so you always look from the start, from a general, and then go in.
I see.
Yeah.
That's definitely very knowledgeable for most of, I would say, for myself and any audience watching us.
Yeah, I try to keep it to just like undergraduate level to begin with. But if you want to go deeper in terms of like postgraduate level, then it's much more deeper than that. And I may not get the knowledge to give you the answer now. Maybe you can interview me 3-4 years later. I can give you a different answer.
Definitely.
But for now, it's still more like personal from what I do from day to day.
Yep. So definitely prevention always beats cure any day. So wrapping up with our final question. So what are some early steps that we can take in order to fix the crooked teeth?
So I think that's one of the favorite questions that people can actually ask in undergraduate, because in UKM, when I was in year 4 and year 5, we do have clinical attachment to orthodontics. So they have this thing called upper removable appliance, which is URA. So usually the cases that they send over is easy fix, that you can actually learn how to do it. So upper removable appliances consist of, number one, acrylic plate. That's what the same thing that you use for denture as well. So acrylic plate to hold the appliances together. And these are like simple crooked teeth that they can fix, but not too hard. For example, when you have an anterior crossbite like that, maybe on one teeth, so the lower incisor is covering the upper incisors. So what you want to do is just to push the upper incisors forward a little bit, just so the upper incisors can cover the lower incisors. That's where you can use something that we call a Z spring or like a T spring to push that forward like that. And the appliances itself has a spring incorporated to it. So it's actually pushing the palatal surface of the upper incisors to move it forward. And then you see the patient after a few weeks or maybe 1 month. Then you see whether they're wearing the appliances. If they wear the appliances, then it can be corrected. So there is one upper removal appliances, but it needs to be prescribed by orthodontists because you want to know what you're doing. Other than that, a lot of early interceptive treatment that we can do. There's class 2 correction, class 3 correction. There is large overjet, anterior open bite. So all these things, if you do see like the beginning of all these skeletal effects, skeletal malocclusion of your friends or your cousin or your nephew, or anyone that's watching this, you have a son that have this problem, then can refer them to a dentist or orthodontist so that they can have a look. There are multiple ways that we can do like growth modification that can help the class 2. I've seen a patient that actually have a very deficient lower jaw and very retrusive, and then we give them something that it was ideal case for something we call Clark twin block. You can learn this in 4th year as well in your undergraduate orthodontic. So Clark twin block is to correct a class 2 skeletal profile. When I first read about it, I have no idea what was that. In undergraduate, I just had to memorize it because I've never seen that before. So when I was in postgraduate now, I've seen it before. I know that it worked. It actually helped to push the lower jaw to become forward a little bit so that they can reach a class 1 incisor relationship. So that's pretty cool. And a lot of different adaptation has done it by Invisalign. They try to do it as well. There are clear aligners. For example, Angel Align that try to do it. There are a few myo braces that try to do it. But all these things, I wouldn't want to give my opinion on it because it's a very big topic. But what I say is always check the evidence. If you want to do something for your patient, you want to know what are you giving to your patient. So research about it, look at the research evidence behind the appliances before just give it like that just because you want the money. Don't do that. Okay?
Yeah. So is that all from Joshua?
Yeah. Or do you want to know more?
To
go 5 days for this?
So that's more than enough for our time being for now. So I want to say thank you very much, Dr. Joshua, for your insights. And that concludes our today's episode featuring with us, Dr. Joshua Pei. So he has shared with us his dental journey and valuable knowledge about malocclusion. So we hope that you found it informative and you'll come back to us tomorrow in our next session. Until then, take care.
Thank you so much for having me.
Yes, thank you very much, Doctor.
Thank you.
Right.